Good afternoon, everyone. For this new episode of TransConnect in June 2023, I am Dr. Mohit Chaudhary, and I am accompanied with me, Dr. Anshika Yadav, who will be taking you through this interesting episode on transfusion practices in obstetrics. To introduce Dr. Anshika, she is an assistant consultant in Department of Immunohematology and Transfusion Medicine from Santokba Durlabji Memorial Hospital and Research Institute, Jaipur. Welcome, Dr. Anshika. She has got many accolades for her. She's got the President Gold Medal for DNB Transfusion Medicine, which was issued by the NB in Medical Sciences. She got the national level DNB exam highest marks in transfusion medicine. In I Try It program 2021, she was the Transfusion Research Young Investigator Training program she attended, and she got a second position in hands-on training HLA course in Indraprastha Apollo Hospital. She also has a AABB cellular therapy certificate program, and she's got several publications in national and international journal. So thank you, Anshika, for coming over and sparing time for this. Just wanted to ask you a thing before we start. How did you select this topic, one? And secondly, do you think really TransConnect helps the students, and how it helps the student if it does?
First of all, good afternoon, everyone. And I would like to congratulate sir for this TransConnect. And thank you, sir, for inviting me to speak on this platform. And I definitely believe TransConnect is very much useful for the student, because I recall when we were residents and when there was some difficult topic, we were not able to get the concepts right. And through this channel, we can see these videos again and again and get the topic in a simpler and concise way. Then it is a very much technology approved program for the students, and they'll learn a lot through this channel. And it was very inspiring to see your commitment towards the education of the students and your desire to make a positive impact through this online platform. That's why I thought that I should contribute a little. And this topic is very plays a very important role in our transfusion practices as well as for clinician too. That is why I chose this topic.
So nice of you to spare time for this. I think it should be helpful to our students who actually are glued to it. We have got now good 650 plus subscriber who actually listen to it. So over to you, Dr. Anshika. And if there is anything that they want to ask, they can write it after they can send a message or something like that after the whole presentation. So over to you, Dr. Anshika, for the same.
Thank you, sir. So let's start the presentation. I'll be discussing transfusion practices in obstetrics, and I will be discussing that topic under the introduction part. Then there will be physiological changes in pregnancy, then maternal screening for alloimmunization. Then we will discuss the antenatal transfusion support, transfusion for planned surgical procedure, and transfusion during emergency procedure, and none other than the management of major obstetric hemorrhage. Then obstetric hemorrhage, we all know that it plays a major cause of maternal mortality worldwide, and it is first leading cause for hemorrhage in India, and in UK it is third leading. And PPH only accounts for 25% of all pregnancy related deaths. That is why it plays a very important topic to read. In anticipated obstetric hemorrhage loss, expected mean blood loss during vaginal delivery is 500 ml. During a routine cesarean section, it is 1000 ml, and in cesarean hysterectomy, it is 1500 ml. Then coming to the physiological changes in pregnancy, we all know that there is increased in red cell mass by 20 to 30%. That is, there is hemodilution, then increase in plasma volume by 50%. Patients stay hemodynamically stable with the normal blood loss during delivery. Then there is decrease in platelets. We can go for gestational thrombocytopenia, and there is hypercoagulable state. There is increase in coagulation factors, especially fibrinogen, factor 7, factor 8, factor 9, and the supervening or the increase in the natural anticoagulants like protein A, protein C, and antithrombin 3. There is decrease in fibrinolytic system activity and increased plasminogen. but its activity is dampened by a corresponding increase in plasminogen inhibitor type 2, leading to a hypercoagulable state, and that will limit the blood loss and can tip the mother into DIC and pulmonary embolism. There is difficulty in assessment of blood loss during pregnancy because of the vital signs. There is increased maternal plasma volume. Then there is hemodilution and high cardiac output state, and visual assessment because large amount of blood loss may be concealed in the uterine cavity. And there are some associated comorbid conditions also, like thrombocytopenia and HELLP syndromes, and there is always a risk to the fetus. Therefore, we should always think of managing acute hemorrhagic emergency. The fetus has to be kept in mind, and to prevent infections and STFN in the current and future pregnancies. Then coming to the antenatal transfusion support. First, we have to look after the anemia, and there are two main guidelines for anemia in pregnancy. First one is BCHS and WHO. In first trimester, if the hemoglobin is less than 11, both of the guidelines recommend the same hemoglobin levels in first trimester. It is called as anemia. In second trimester, if the hemoglobin levels less than 10.5 grams, but in third trimester, both of these differ. According to BCHS, if it is less than 10.5, then it is anemic, and WHO says that if the hemoglobin is less than 11. Then in postpartum period, if the hemoglobin is less than 10, it is anemic. And then it is always better to reduce the risk of blood transfusion, and it is done by optimization of hemoglobin in antenatal period. And what we can do screening for that at the time when the patient visits to the antenatal clinic, and then at the 28 weeks. And for multiple pregnancies, we can do the screening in 20 to 24 weeks. Then prevention of anemia, it will reduce the need for transfusion. And how can we prevent the anemia? By adequate maternal and child health, by nutrition. And for more anemic patient, we can go for prophylactic and iron and folic acid administration. Its optimum dose is 120 milligram elemental iron and 1 mg of folate. And for higher doses, if anemia is already present, that is 180 mg of iron and 2 milligram of folate. Then JAPAC guidelines for screening of RBC alloantibodies in pregnancy. We should do the screening at booking, like 12 to 16 weeks, whenever the patient comes to our antenatal clinic first time. And if any allo antibody capable of causing SDFN is detected, for example, any anti-D, C, K, we should confirm that in our reference laboratory, and we have to issue an antibody card to the mother and seek the specialist clinical advice. And in these cases, determining the father's phenotype helps to predict the likelihood of a fetus carrying the relevant red cell antigen. And regular repeat testing during the second trimester of clinically significant alloantibodies, every 4 weeks to 28 weeks gestation, and then every 2 weeks to term. Referral to a fetal medicine specialist is recommended once the anti-D levels are more than 4 international units per ml, and in case of anti-C, if it is more than 7.5 international units per ml, and in any woman with anti-K, because anti-K has the severity of fetal anemia, and which is unpredictable in that case. Therefore, any titer of anti-K is, we have to refer that to fetal medicine specialist. All other women should have repeat antibody screening at 28 weeks gestation to exclude late development of red cell alloantibodies. And then this is the process flow for pre-transfusion testing. Whenever the patient comes, and if it is a booked case or non-booked case, we have to go for type and screen, and we can do typing of ABO and RH blood group typing. And if the antibody screen is negative, we can go for electronic cross match. But in India, it is still not feasible. And if in case the screening is positive, we can go for identification, and in case the patient needs the blood, we can procure antigen negative units for that patient. Then RCOG Green Top guidelines for blood product specification always use ABO and RH compatible red cell unit for the patient who needs transfusion in pregnancy. And if any clinical significant red cell antibodies are present, Then blood negative for relevant antigen should be cross-matched before transfusion. And if the pregnant female or any women of childbearing age who are Rh negative must only receive Rh negative blood to avoid the risk of Rh alloimmunization. Then what are the factors we should consider during RBC transfusion in pregnancy? We should always look for stage of pregnancy, any evidence of cardiac failure, any presence of any infection, her obstetric history, the anticipated delivery mode, like either it is vaginal or cesarean, and hemoglobin level of the patient. And in case of absence of major hemorrhage, the decision to transfuse should be made after careful clinical assessment rather than on the basis of a specific hemoglobin concentration. During the first and second trimester, when we should transfuse blood, if the anemia is due to hematinic deficiency, we should treat the patient either with oral iron or parenteral iron, and transfusion is not indicated in that case. And if the patient is clinically stable and healthy women with hemoglobin of 7 to 8 gram, they can usually be managed with oral or parenteral iron, and there is no need of transfusion in those cases too. But when the patient is having hemoglobinopathies or any bone marrow failure syndrome, they should be managed by blood transfusion. And if the patient is in third trimester, if she is less than 36 weeks or she has delivery in more than 4 weeks, what we can do? If her hemoglobin is less than 5 or 5, even without signs of cardiac failure or hypoxia, we can go for transfusion. And if her hemoglobin is between 5 to 7 grams, and there are some following conditions, for example, if there is established or incipient cardiac failure or clinically evidence of hypoxia, then we can go for blood transfusion. Any pneumonia or any other serious bacterial infection or any pre-existing heart disease not casually related to anemia, then we can go for blood transfusion. Then again in third trimester, if the patient is more than 30 weeks, 36 weeks, or delivery is in less than 4 weeks, or if the patient is in labor and her hemoglobin is 6 or less than 6, even without the signs of cardiac failure, we can go for blood transfusion. But if her hemoglobin is between 6 and 8, and there are some conditions which I have already told you before, that if there is pneumonia or pre-existing heart disease, and if there is signs or symptoms of cardiac failure, then we can go for blood transfusion in those cases. During vaginal delivery, if her hemoglobin is more than 10 gram per cent, there is no need to transfuse the patient. If the hemoglobin is between 8 to 10 gram and there is symptoms of cardiac failure, any bacterial infection, and any pre-existing heart disease, then we can go for transfusion. And if her hemoglobin is less than 8, even without signs of cardiac failure or hypoxia, we have to transfuse the patient. And but in postpartum period, if her hemoglobin does not return to normal by 8 weeks postpartum, we can go for hematological reference, and investigation should be done for that, for those cases, and then we can go for transfusion. If the patient, and then coming to the elective cesarean plan, if the patient is going for elective cesarean and there is history of any antepartum hemorrhage or postpartum hemorrhage or in previous cesarean section before, and her hemoglobin is between 8 to 10 gram, we can establish or confirm group and screen, and then we can go for group and cross match for that patient. And if hemoglobin is less than 8 gram, then 2 units should be cross matched and available at that time. The MS was that time should be 2 units, type and cross match. Then coming to the postpartum hemorrhage, and it is, I think, the most important part of the transfusion practices in obstetrics, because it is the most common cause of major obstetric hemorrhage, and it is of 2 types, either primary PPH or secondary PPH. Primary PPH is loss of more than 500 ml of blood from the genital tract within 24 hours of the birth of a baby. Whereas the secondary PPH is defined as the excessive bleeding from birth canal between 24 hours and 12 weeks postnatally. Then coming to primary hemorrhage, it is mainly of 2 types, minor or major. Minor is less than 1 liter and major is more than 1 liter. Then coming to major is also subdivided into moderate and severe. Moderate is up to 2000 ml and severe is more than 2 liters of blood loss. Then major obstetric hemorrhage, it is defined as the need for transfusion of at least 4 units of blood, and it is the most common cause of PPS. And then there comes massive. There is difference between major obstetric hemorrhage and massive hemorrhage. Major is when we require only 4 units of transfusion, but when massive comes, there is more than 10 units over 24 hours transfusion. And if there is total blood volume replacement within 24 hours, if this definition criteria is same as that massive transfusion, and if there are 4 units of RBC transfused within 4 hours, and with active major bleeding of more than 150 ml per minute. Then these are some of the causes for obstetric hemorrhage. During antepartum period, we can go for abnormal placentation. There can be large uterine fibroids, preeclampsia, any placental abruption, and any pre-existing coagulopathy. They can contribute to antepartum part. Then during postpartum part, there can be active bleeding on admission. There is prolongation of labor, induction of labor, either baby weight more than 4 kgs, if the patient has been gone for emergency cesarean section, or retained placenta. Then how can we manage the major obstetric hemorrhage with blood components? And then comes to the massive hemorrhage part. Then coming to the major obstetric hemorrhage part, the decision to perform blood transfusion should be made on clinical judgments and as well as laboratory based parameters. And it is required when hemoglobin is less than 6. And it is rarely required when there is hemoglobin of more than 10 grams. And we should always remember that if the patients with acute hemorrhage can have normal hemoglobin, hence the clinical evaluation of the patient in this situation is extremely important. And these are from RCOG Green Top Guidelines 47. Then when can we use FFP during major obstetric hemorrhage? It should be used as at a dose of 12 to 15 ml per kg, and it should be administered for every 6 units of red cell during Hemorrhage. And the subsequent FFP transfusion should be guided by the clotting tests, and we have to aim the PT and APTT ratios at less than 1.5 times normal. Then when can we use cryo? Cryo should be used at a standard dose of 2 5-unit pools, and it should be administered early in major obstetric hemorrhage. And subsequent cryoprecipitate transfusion, it should be guided by fibrinogen results and aiming to keep levels above more than 1.5 gram per liter. When the combination of FFP and cryo should be used, because we all know that during pregnancy, fibrinogen levels increases above normal ranges. It is almost a double, and it is between 3.5 to 6.5 grams per liter, and risk for severe PPH is 2.6 times higher for each 1 gram decrease in the fibrinogen. And we all know that the decrease in fibrinogen levels is early predictor of PPH. Therefore, we should go for early testing during obstetric hemorrhage, and fibrinogen plays a very important role and crucial part during hemorrhage in that time. 2 packs early, that is 2 packs, 1 pack consists of 5 units of cryo in Hemorrhage, and subsequent transfusion is guided by the fibrinogen results, and we have to aim the fibrinogen levels more than 1.5 grams. When should we transfuse the platelets? We should aim to maintain a platelet counts above 50,000 in case of acutely bleeding patient, and if the patient if a platelet transfusion trigger of 75,000 is recommended to provide a margin of safety for that patient. Platelets should ideally be group compatible, and RSD negative women should also receive RSD negative platelets. But in case whenever there is emergency, and in order to avoid the development of anti-D antibodies, whenever the patient is transfused D compatible platelets, like D negative patient transfused with D positive platelets, we can give a dose of 25 international unit anti-D immunoglobulin subcutaneously, and it is sufficient to cover 5 adult therapeutic doses given within a 6-week period. Then risk stratification for blood ordering, because it is useful for pre-delivery transfusion testing and blood ordering, and all patients undergoing screening for unusual antibodies. And if the unusual antibodies are present, then cross-matching in the antepartum period is advised, because a serological cross-match can be slow. And if unusual antibodies are not present, then low or medium risk patient may not require cross-matched blood to be ordered before delivery. Therefore, if the blood is urgently needed, we can go for O negative RBCs, and in case of life-threatening hemorrhage, we can go for uncross-matched transfusion. Then coming to the massive hemorrhage part, I have already covered the definition part of massive hemorrhage. Then how can we manage the active hemorrhage? Because the concept of damage control resuscitation should be followed to address the lethal triad of coagulopathy, acidosis, and hypothermia. And early transfusion should be used to mitigate the risk of coagulopathy associated with bleed. Therefore, to facilitate rapid transfusion of large quantities of blood products to a massively bleeding patient, a massive transfusion protocol is followed. Then coming to the role of tranexamic acid during massive hemorrhage, there has been two studies, two trials. First one is women trial and then crash trial. It has shown to reduce the rate of bleeding and improve survival rates in acute hemorrhage in PPH, and it should be given as soon as possible, because every 15-minute delay in Trenexa can decrease the survival by 10%, and it should be used in 1 gram bolus dose, and it should be followed by 1 gram infusion or 8-hour period. Then this is the women trial. It showed that the drug could save by 1/3 of the women who would otherwise bleed to death after childbirth, and if it is given within 3 hours of giving birth. Then again, the crash trial, it is also showed that early administration of Trenexa is reduce the risk of death in bleeding patient, and it is highly cost effective, and treatment beyond 3 hours of injury is unlikely to be effective. Then coming to the role of point of care testing, the POCT is tag and ROTEM always it plays an important role, and it is better than using the goal-based transfusion therapy in massive hemorrhage. The ratio-based transfusion in massive hemorrhage, it is transfusion of plasma to platelet to red blood cell ratio, and it should be always in 1:1 ratio, because or 1:1:2 ratio, whatever your institute say, you can go for that protocol. Then a role of fibrinogen in obstetric patient, we can go for IV fibrinogen concentrate 4 gram or cryoprecipitate 10 units. That is 2 pools in case of life-threatening hemorrhage. That is early administration of fibrinogen can lead to better results. Then coming to the CMQCC obstetric hemorrhage staging, and it consists of 4 stages. Stage 1 is when there is blood loss of more than 500 ml post vaginal delivery and more than 1 liter during cesarean delivery with normal vitals, labs, and clinical picture. In stage 2, blood loss is between 1 to 1.5 liters with normal vitals. In stage 3, if the blood loss is more than 1.5 ml, or there is a brisk bleeding, and there is a decrease in more than 4 gram of hemoglobin, and there are laboratory evidence of coagulopathy or acidosis and new onset of the altered mental status or lethargy. Then stage 4, it is cardiovascular collapse due to profound blood loss. And what we can do in as a transfusion medicine specialist in those cases, in stage 0, if there is medium risk, we can go for type and screen. And if there is high risk, we can go for type and cross-match 2 units. And in cases of positive antibody screen, we can go for prenatal or current. We can exclude low level of NTD from ROGA, and then type and cross-match 2 units will be sufficient. Then in stage 1, again, if there is change in vital signs by 15%, or there is increased heart rate that is more than 110, or less BP is less than 85/40, we can go for type and cross-match 2 unit PRBC if it is not already done. In stage 2, we have to activate the blood bank because there is continued bleeding with total blood loss under 1.5 liters. And we have to bring 2 units of PRBCs to bedside as soon as possible and transfuse per clinical signs. We need not to wait for the lab values in that case, and blood warmer is always recommended during massive transfusion. And we should always consider thawing of FFP, because FFP thawing takes more than 30-35 minutes. So we can transfuse 2 PRBCs first and then determine the availability of additional PRBCs and FFP according to the lab parameters. Then in stage 3, if the total blood loss is more than 1.5 liters or more than 2 units PRBCs has been already given and the patient has been shifted from major hemorrhage to massive hemorrhage, we can transfuse aggressively, and we can go for massive hemorrhage pack, that is one is in the ratio of 1:1:1, that is plasma to platelet is to PRBCs, or we can go for one pool of cryo, that is 5 units of cryo. And if your institutes had the facility of recombinant factors, then we can go for recombinant factors also, or fibrinogen dosing can be given at that time. This is massive transfusion protocol. During round 1, we can go for 6 unit of each of PRBCs, FFP, and platelets. And then in round 3, during massive hemorrhage in obstetric only, we can give Trenixa 1 gram IV over 10 minutes because it shows better results. And then again, if the patient requires more blood, we can go for round 4. Otherwise, we can terminate the massive hemorrhage protocol. Then coming to the end, what is the role of intraoperative cell salvage during obstetric hemorrhage? It is recommended for non-obstetric patients who are undergoing elective or emergency surgical procedures when the anticipated blood loss is good enough to induce anemia or expected to exceed more than 20% of the estimated blood volume. And it should only be performed by the multidisciplinary teams who develop regular experience of intraoperative cell salvage. And this is end of my presentation, and the take home message is we can go for a type and screen policy at your institute before at the time of booking of the patient or whenever the patient comes. It will be really helpful, and making a massive transfusion protocol for your institute will be better for the major hemorrhage or massive hemorrhage. Thank you.
Thanks, Dr. Anshika, for covering this very, very important topic. You have really done justice to it, and I'm hopeful that everybody is going to find it very useful. Just small comment on what you have said. It was a very exhaustive topic. You have covered all the aspects of the women health in this, especially related to the transfusion medicine. You have covered briefly massive transfusion protocol, that is 1:1:1, and spoken about the components that are used to it. You have also talked about tranexamic acid, and I just want to say that we can give an upfront 2 gram dose also. Sometimes we tend to miss the second dose because there is a lot of hush going on. So that can be one way of doing it. You talked about cryoprecipitate. Its importance has to be there, and people tend to forget that cryoprecipitate should be given in special conditions. And you spoke about TEG and ROTEM. So that will be another topic for us. And hopefully we'll be covering the same in the TransConnect as well. So stay tuned for it. And I'm so very thankful to you for covering this topic so elaborately and so nicely.
Thank you. Thank you so much, sir.
Thank you.